I think we've seen updates from two formerly very practice-changing studies, in the Keynote 426 study and the CLEAR study. This was long-term follow-up, so I think while these weren't practice-changing further, they really clarified with longer follow-up that the overall survival benefit in the overall population was still there. So I think that's just reaffirming more of the data that we've had in the past. One thing to note, I think in the favorable risk group, we're kind of getting more information about that group, and just leaving the statistics aside for a second, the favorable risk subgroup in those studies, and both of them didn't seem to do so much better than the control arm when you look at it kind of qualitatively. So I think that doesn't really change my practice necessarily because in the overall study, it was definitely a positive study. So I think I would still offer combination therapy to those patients, whether that's IO-TKI or IO-IO. I think that's a really important and open-ended question. David Braun, who did the discussion for the presentations this morning, I think had a really great algorithm to look at how he would consider it for his patients. And so I think there's multiple factors that go in there that kind of to do a kind of patient-by-patient kind of personalized approach instead of a de facto right answer for everybody. Yeah, and this is going to be the final analysis, I think, for both studies. So I think we're kind of left, that's going to be what we're going to use moving forward. They also presented some cool subgroup analyses. I know those are kind of different ways to look at the data. One of the things that they showed that I thought was really interesting, for patients who completed 2 years of pembrolizumab, they showed that that 85% of the patients had a response in that group who completed 2 years. So that means that we're 15% of the patients who only had stable disease as their best response in that subgroup. So it means that they had a really durable benefit, so to speak, even though they only had stable disease radiographically. So I think that just kind of highlights that maybe just imaging isn't going to be enough when we're trying to figure out if our therapies, especially with immunotherapy, because sometimes they have very lasting benefits. Some of those disease control findings could be durable for some of those patients. Something that's really important, interesting, maybe influence how we look at like early phase studies with immunotherapy, and not just base it only on overall response rate, but also disease control, and then try to find some biomarkers. Ideally, that'd be great to try to figure out, which of these immunotherapy patients are having a good stable disease versus a not so good stable disease. I don't think it changed things significantly. I think we kind of gotten familiar with the toxicity profile of both of these combinations. I think they're manageable, so I don't think there was anything too dramatic there. Sure, yeah, so we did a project along with some great collaborators and colleagues with Caris, and we looked in their database. They have a huge number of patients that they've done molecular sequencing, so DNA and RNA sequencing, through their program of testing clinically. So we looked in their database, and we looked at an entity in prostate cancer that's a relatively new addition to the WHO criteria. It's called intraductal prostate cancer. So this is the type of prostate cancer you'd identify by looking under the microscope and seeing some features that a pathologist can recognize and then classify it as intraductal. Clinically, what we know about intraductal prostate cancer is that it's associated with a much more aggressive disease clinically. So, and that's what we saw in our study too. 85% of the patients in our group had very high grade group disease. So that's kind of a prognostic marker in prostate cancer that we use. And another thing that we saw is just kind of the molecular landscape of alterations there. And one notable finding is we did identify kind of some actionable targets already in BRCA1 and 2 mutations, CDK12 mutations, and a couple others like AKT mutations. So those are things that might be able to help patients kind of now. And then looking ahead, we're trying to develop more robust cohort, kind of increasing the number of cases that we're going to have. We're also going to try to get a pure adenocarcinoma cohort to compare, to see really on the RNA side what's really unique about intraductal prostate cancer. Put all that together in the future, we're going to try to figure out if we can do something different to treat these patients. Right now, I think these patients still follow the standard of care. They tend to present with like bigger tumors, and that can be a challenge sometimes, and they have a higher risk of metastatic disease. So we just have to be aware of that. But in the future, maybe we can customize things for them a little bit better. I think we still have to do some more work on that. I think the sample size we had is relatively small. We had about 31 cases. I think once we have a more robust cohort size, we'll be able to identify that with a little bit more confidence. I think, AKT is one of the things I mentioned. There are drugs that target it already. They're in development, so I think, they're not specifically being developed in prostate cancer patients with intraductal, but more broadly. So we might be able to look at that in the future, and I think that's something that's in clinical trials. Maybe we can focus that more in on this patient population in the future once we learn a little bit more. I think the line of research is really trying to figure out, is there something different about these patients that we could customize further, whether that be treatment before surgery, since they tend to have bigger tumors. That's not something we do routinely in prostate cancer, but maybe that would be a good idea in this patient subset. Just in general, how we might be able to escalate therapy in a scientifically, smart way to try to kind of help these patients as best we can. So I think it's a work in progress. It's kind of a first investigation on our part. There's some other work in the field, but it's still relatively not well studied.